Hi, Yampa Valley Medical Associate Team. My name is Erin Weber, and as you may or may not know, I've been precepting with Dr. Hoffenbeck this semester as I work towards my doctorate of nursing practice. This semester, I've been focusing on care of the older adult, those aged 65 and older. As part of the coursework, I have been charged with providing a service learning project to my clinical site. The topic I chose to focus on is insomnia in older adults. It is no secret that sleep is a problem for many individuals. Over half of the older adult population in the U.S. reports at least one sleep complaint. Specifically, insomnia is reported by 31 to 38% of adults aged 18 to 65 and 45% of adults aged 65 to 79. For the purposes of my course this semester, I'm going to focus on older adults. Over the next few minutes, I'm going to review the problem of insomnia, challenges in managing it, and provide some tips and ideas to hopefully overcome some of these challenges. Numerous factors contribute to the high prevalence of insomnia in older adults, including psychiatric and neurological disorders, medical comorbidities, polypharmacy, adverse effects of medications, substance abuse, decreased sensory input, namely visual and auditory, unrealistic expectations of sleep, lifestyle changes such as retirement and change in daily structure, environmental changes from home to hospital to care facilities, and psychosocial stressors. Moreover, research indicates that with aging, more time is spent in the light sleep stages and less time is spent in REM and deep sleep. As a result, sleep is more fragmented, and older adults often report waking up earlier, prolonged period to fall asleep, more nighttime awakenings, and decreased total sleep. It is well known that quality sleep can improve measures of quality of life, cognitive functioning, and health outcomes, whereas poor sleep is associated with serious negative physical, mental, and social consequences. Insomnia in the older adult population has been closely linked to cognitive difficulties, mood disorders, poor daily functioning, increased risk of falls and nursing home placement, increased incidence of cardiovascular disease, increased multi-system biological consequences, and all-cause mortality. All too often, insomnia is unrecognized and untreated in older adults, resulting in preventable sequelae. And unfortunately, despite the well-documented prevalence of insomnia in the older adult population, in a query of the National Guideline Clearinghouse, up to date, the American Geriatric Society, the American Academy of Sleep Medicine, and a Google engine search of clinical practice guidelines for sleep disorders in elderly or older adults or geriatrics, there are no broad clinical practice guidelines specifically for this population. Therefore, at this time, the general guidelines for assessing for sleep problems and insomnia will have to be used. Up to Date recommends that we have the patient complete a medical psychiatric questionnaire, the Epworth Sleepiness Scale, the Insomnia Severity Index, or the Pittsburgh Sleep Quality Index, and a sleep diary. Since I chose to focus on insomnia this semester, I'm going to review the ISI and propose that it be implemented into your assessment for patients with suspected or diagnosed insomnia. This ISI has 7 questions that patients fill out, or you can assist them to fill out. It is scored 0 to 28 with higher scores correlating with increased severity of insomnia. The instrument asks patients to rate their problems falling asleep, staying asleep, and waking up too early on a scale of 0 to 4. It asks how satisfied or dissatisfied they are with their current sleep pattern, how noticeably the problem impairs their quality of life, how worried or distressed they are about the problem, and to what extent they feel that it interferes with their daily functioning. The test-retest reliability as well as the internal consistency of the ISI is high, and the literature suggests it is a strong tool for evaluating insomnia in primary care settings. So what do we do if our patient scores high on the ISI? Unfortunately, the majority of sedatives and hypnotic agents available to treat insomnia are on the Beers list. And currently, as part of the Choosing Wisely campaign, the American Board of Internal Medicine advises against the use of hypnotics as first-line therapy for adults, and recommends cognitive behavioral therapy for insomnia, or CBT-I. Now you're probably thinking to yourself, CBT-I, yeah, okay, like I have time to provide this during the office visit. Widely recognized limitations to widespread implementation of CBT-I include lack of awareness, time for instruction, lack of credentialed providers, and reimbursement. So in addition to reviewing the methods now, I've provided patient handouts that you can distribute, posters that can be hung around the office, as well as some resources that you may not have previously considered. Briefly, the cognitive aspect of CBT-I teaches individuals to recognize and change beliefs that affect their ability to sleep, and the behavioral aspect helps them to develop good sleep habits and avoid behaviors that keep them from sleeping well. There are 7 methods. The first is stimulus control. This aspect focuses on removing factors that condition the mind to resist sleep. You might coach the patient to set a consistent bedtime and wake time, avoid naps, reserve the bed only for sleep, leave the bedroom if they cannot sleep within 20 minutes, and return when they're more tired. The second is sleep restriction. This aspect focuses on restricting the time individuals spend in bed to as close to their estimated total sleep time. It can be very effective to use a sleep diary to help guide this restriction. For example, if a patient reports they went to bed at 10 p.m. and woke up at 6 a.m., but only estimate they slept 5.5 hours, you would guide them to go to bed closer to 11:30 and wake up around 5. The third is sleep hygiene. In this aspect, you target lifestyle habits that influence sleep, such as smoking, drinking caffeine too late in the day, alcohol consumption, or not getting regular exercise. In general, the recommendation is to avoid smoking, alcohol, caffeine, and rigorous exercise for at least 4 hours prior to going to bed. Sleep environment improvement. The goal here is to create a calm, dark, relaxing environment to support sleep. This includes keeping the bedroom dark, quiet, and cool, removing TVs from the bedroom, and hiding the clock from view. The fifth is relaxation training. This may include techniques such as meditation, imagery, and progressive muscle relaxation. The sixth is remaining passively awake. This is a paradoxical action in which you have individuals focus on avoiding any effort to fall asleep. The idea is that individuals will then release the worry about not being able to fall asleep and relax, making it easier to fall asleep. And the seventh, biofeedback. Generally, a sleep specialist would direct this intervention, providing the individual with a biofeedback device, with sensors placed on the feet or in a headband that can track muscle tension or brain rhythms and assist in identifying factors that affect sleep. Now, you might also consider web-based adjuncts. The Conquering Insomnia program replicates the CBT-I program developed and tested at Harvard Medical School and the University of Massachusetts Medical Center by Dr. Greg D. Jacobs. The Conquering Insomnia program is a 5-session, 5-week PDF-based treatment. It is interactive and allows participants to complete a sleep diary each week of the program, email it, and receive interactive, individualized CBT-I guidelines based on their sleep diary. The costs range from $49.95 to $69.95 for individual participation. There's also a clinician training manual and webinar ranging from $195 for solo clinicians to $395 for institutions. So after addressing other modifiable factors such as sleep apnea, depression, and adverse effects of medications, if your patient scores high on the ISI or expresses concerns about their sleep, I encourage you to familiarize yourself with a few of these methods before jumping to a pharmacologic agent. Moreover, I have provided patient handouts for you to distribute, as well as a few posters that can be hung around the office or in the bathroom. In talking to patients about the CBT-I method, it is important to set appropriate expectations and let them know that on average it takes 6 weeks to see a noticeable improvement in sleep. I thank you for your time, and if you don't mind, I have included a link in the email to a quick online evaluation.